Welcome to the second video on our alcohol use disorder curriculum. Today you will be learning about the medications that we can provide to help care for patients struggling with alcohol use disorder. Remember, unhealthy alcohol use is a spectrum. Medication is most helpful for patients with moderate to severe alcohol use disorder. Before we get into the weeds about medication prescribing, let's remember our options for treatment. Last week we talked about mutual support groups and psychotherapeutic models. This week, we're going to focus on medications that we can prescribe to support patients seeking treatment for alcohol use disorder. It's important to remember, though, that medications are always studied in conjunction with psychosocial recovery programs, and that psychosocial support is considered a standard of care part of treatment for alcohol use disorder. We should also review the two broad approaches to the goals of treatment for alcohol use disorder. Traditionally, treatment for alcohol use disorder focused on complete abstinence from alcohol use. Indeed, alcohol cessation is critically important for many patients, especially those with certain alcohol-related medical or psychiatric diseases and those who've struggled with moderation in the past. We touched on this goal last week when we talked about AA, LifeRing, and Women for Sobriety, as all three of these organizations define successful recovery in terms of complete abstinence from alcohol. At the same time, some patients want help reducing their drinking but don't feel able or ready to stop drinking altogether. Instead, these patients are interested in other goals, like cutting down on how much they drink or how often they binge drink. Other patients may be mostly focused on functional goals or health outcomes goals, like avoiding the need for emergency room visits or improving job performance. Studies looking at medication for alcohol use disorder typically look at multiple outcomes, including both complete abstinence from alcohol use and a reduction in overall alcohol use. Fortunately, at least one 2019 study suggested that decreased alcohol consumption can be sustainable over time and is associated with improved function, even in patients who don't stop drinking entirely. It's really important to have an understanding of what your patient's goals for alcohol use treatment are, because some medications are more effective than others for specific goals. We're going to talk about 4 medications today. There are 3 FDA-approved medicines for alcohol use disorder: acamprosate, naltrexone, and disulfiram. Topiramate is not FDA-approved, but there is strong evidence that it's at least as effective as the FDA-approved medications. Let's start with naltrexone. Naltrexone is an opioid receptor antagonist that decreases the rewards associated with drinking. It comes in both long-acting injectable forms and oral forms, though the injectable form is much more expensive than the oral form. As an oral medication, naltrexone is usually prescribed at a dose of 50 milligrams a day, but that dose can go up to 100 milligrams a day. In the long-acting injectable form, 380 milligrams of naltrexone are injected intramuscularly every 4 weeks. Naltrexone is effective, though, to be honest, quantifying exactly how effective is a matter of some controversy for naltrexone and for all medications used in the treatment of alcohol use disorder. One meta-analysis published in 2014 in JAMA estimates that 20 people need to be treated with naltrexone to prevent 1 person from returning to any drinking, and 12 people need to be treated with naltrexone to prevent 1 person from returning to heavy drinking. This means that there is evidence to support the use of naltrexone, both for people who are trying to stop drinking completely and for people who are trying to reduce their alcohol use. All of the numbers that I just cited are calculated from data on oral naltrexone. Oral and injectable naltrexone formulations have never been compared in a randomized trial for the treatment of alcohol use disorder. Nonetheless, I do recommend injectable naltrexone for patients who struggle to take oral medications regularly. Often, patients who need injectable naltrexone benefit from referral to an addiction specialist for treatment, and sometimes that's the only way that injectable naltrexone can be covered or administered. Generally, naltrexone is very safe. Like all medications, though, there are a few special situations that require attention. Because naltrexone is a direct opioid receptor antagonist, it can't be used in patients who are physically dependent on opioids because it can precipitate acute withdrawal. It's unclear exactly how long you have to wait between the last exposure to an opioid and the initiation of naltrexone, but VA guidelines recommend waiting for about 10 days. Many people with co-occurring opioid and alcohol use disorder may prefer a different medication for their alcohol use disorder so that they can use methadone or buprenorphine to treat their opioid use disorder. Others may choose to use naltrexone because it has FDA approval for the treatment of both opioid and alcohol use disorders, though it's less effective in treating opioid use disorder than methadone or buprenorphine. Another patient population that deserves some special attention is people with co-occurring depression and alcohol use disorder. Initially, there was concern that naltrexone might be associated with increased rates of depression, though more recent studies haven't seen this association. Remember, alcohol use disorder in and of itself predisposes to mood disorders and suicide completion, so undertreatment of alcohol use disorder is also not risk-free. Generally, I think it is safe to prescribe naltrexone in patients with a history of depression or with ongoing depression. The most common side effects of naltrexone are GI-related, either nausea, decreased appetite, or more rarely diarrhea. Naltrexone can be used in child's PU class A and B liver disease, but it's contraindicated in patients with acute hepatitis, decompensated liver failure, or renal disease with a creatinine clearance less than 30. According to VA prescribing guidelines, LFTs should be checked before starting naltrexone and 6 months after initiation, and then annually thereafter. Next, let's talk about acamprosate. We believe that acamprosate moderates GABA and glutamate balance in the brain, though the exact mechanism of action is honestly a little bit fuzzy. Acamprosate is prescribed at a dose of 666 milligrams 3 times a day. It's the only medication for the treatment of alcohol use disorder that is safe regardless of hepatic function. Acamprosate is effective, though again, quantifying efficacy is controversial. In the 2014 JAMA meta-analysis I already alluded to, 12 people needed to be treated with acamprosate to prevent one person from returning to any drinking. The confidence intervals for acamprosate and naltrexone overlap, so I think of these two medications as similarly effective for promoting complete abstinence from alcohol. Acamprosate has not been shown to reduce heavy drinking among patients who don't stop drinking altogether, at least not in clinical trials. Therefore, acamprosate is best suited to people trying to stop drinking completely. Despite acamprosate's many advantages, it's worth noting a few drawbacks. Most importantly, this medication is dosed 3 times a day, which is an obvious barrier to adherence. Like naltrexone, there is some concern that acamprosate may be associated with worsening depression or suicidal ideation. Again, though, alcohol use disorder itself is associated with these conditions, so it's usually safe to start acamprosate even in people with depression. The most common side effect of acamprosate is diarrhea, which is seen in about 10% of patients. Also, acamprosate requires dose adjustment for creatinine clearance between 30 and 50, and it shouldn't be used once creatinine clearance falls below 30. Therefore, we should monitor renal function about annually in patients on acamprosate who are at risk for the development of CKD. The last FDA-approved medication for the treatment of alcohol use disorder is disulfiram. Disulfiram is an enzyme inhibitor that prevents the body from converting acetaldehyde to acetic acid, and the buildup of acetaldehyde makes people feel sick. This reaction is supposed to be so unpleasant that it deters people from drinking alcohol at all. Therefore, disulfiram is only appropriate if the patient's goal for treatment is complete abstinence. Disulfiram is dosed at 250 milligrams once a day. It's essential that the patients have absolutely zero alcohol in their bodies before taking the first dose, not just that they don't appear clinically intoxicated. If there's any doubt at all, blood alcohol levels can be checked to ensure that it's safe to start disulfiram. Of the medications for alcohol use disorder, self-administered disulfiram is probably the least effective. The best results for disulfiram are seen in open-label trials in which medications are administered or monitored by an outside party, like a family member or a parole officer. Unfortunately, disulfiram interacts with many important medications, including anti-epileptic medications, warfarin, and metronidazole, just to name a few. The reaction between disulfiram and alcohol can be triggered by even trace amounts of alcohol, like what you might find in food, mouthwash, over-the-counter medications. It's important to counsel patients about these reactions before you give the medications so that they don't accidentally experience the alcohol disulfiram reaction. Furthermore, the alcohol disulfiram reaction can be not only unpleasant, but actually dangerous. Because of this danger, disulfiram is relatively contraindicated in patients with pulmonary, cardiac, renal, or hepatic dysfunction who may be less able to tolerate the reaction or less able to eventually clear the drug. Disulfiram is also not appropriate for patients with cognitive impairment who can't understand the consequences of drinking while on the medication or who might forget that they took disulfiram. Finally, disulfiram has been associated with acute psychosis when combined with dopaminergic medications, and it shouldn't be used in patients with a history of known psychotic disease. The last medication that we're going to discuss today is topiramate. Topiramate is safe in patients with liver disease as long as they don't have a history of hepatic encephalopathy. Topiramate, like naltrexone, is moderately effective at helping people reduce heavy drinking and at helping people stop drinking alcohol completely. Topiramate is more complicated to dose than the medications that we've already discussed because it has to be started slowly and up-titrated over time. I usually start with 25 milligrams a day for 1 week and then go up by 25 milligrams a day every week until I reach a goal dose of 100 milligrams twice a day. Higher doses than that are associated with more side effects and don't seem to improve drinking outcomes. One of the advantages of topiramate is that many generalists are already comfortable with topiramate because of its utility in other common disorders like migraine headaches, and it's considered a reasonable first-line treatment option in some provider guidelines, like those released by the VA and the Department of Defense for the treatment of alcohol use disorder in primary care. However, because topiramate for alcohol use disorder is off-label, other experts argue that generalists should preferentially choose FDA-approved medications and reserve off-label prescribing for addiction specialists in the management of refractory alcohol use disorder. The most troubling side effect of topiramate for most patients is that it can cause fatigue, psychomotor slowing, and a feeling of fogginess or grogginess. The mental status changes can be particularly problematic for patients who continue to use alcohol during treatment, which in and of itself can cause psychomotor slowing and fogginess. It's also associated with paresthesias and decreased appetite. Topiramate is renally cleared and has to be dose reduced for people with renal disease, and it shouldn't be used in patients with a history of kidney stones. Finally, topiramate is teratogenic and decreases the efficacy of many forms of hormonal contraception, so we need to be thoughtful about prescribing it in women of reproductive age. Unfortunately, many patients continue to struggle with alcohol use disorder despite medication therapy, or they return to alcohol use after a period of not using alcohol. When this happens, I think it's an indication to increase the psychosocial support that patient is receiving and to consider whether the patient needs a higher level of care, like intensive outpatient or residential treatment. I also consider switching to a medication with a different mechanism of action. Because clinical trials haven't shown a benefit to combining medications for alcohol use disorder, I don't usually add on a second medication in the primary care setting. So we've been through a lot of material today. Let's just recap the key points. Disulfiram, acamprosate, and naltrexone are all FDA-approved medications to help with alcohol use disorder. Naltrexone is a once-daily medicine for people who are interested in either stopping drinking altogether or in reducing their alcohol consumption, and it's available in long-acting formulations for patients who struggle with adherence. Acamprosate is the medicine of choice for patients with advanced liver disease and patients on full or partial opioid agonists, and it's effective in helping patients stop using alcohol completely. Topiramate is likely an effective medication in helping patients reduce or stop drinking alcohol, but it's not FDA approved for this indication. Finally, patients with alcohol use disorder should be offered referrals for counseling and encouraged to attend mutual support groups in addition to the medication that they're taking.